So, Moni, have you ever thought about what might be the worst time of the year for our mentally unwell patients?
Yes, but I want you to answer it so that everyone can blame you for this.
March Madness.
Still hoping to be able to fire you for one of these days, but
Not going to happen.
do we get to credit? Is that the Dr. Noble Malik special?
Sure is.
Yeah.
I get zero credit for it.
Yeah. If it's a good pun, it's probably his.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Moral Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we are responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to Curbsiders. I'm Dr. Moni Amin, joined by my effervescent co-host, Dr. Meredith Schubert. We are still in San Diego, Meredith.
We sure are.
But the listeners don't actually know that, so we're just reminding everyone that we're at SHM, one of the best conferences of the year, and we're in San Diego this year. And this episode is going to be a great episode that we're doing on kind of psychiatric clinical liaison type stuff with our guest, Dr. Aaron Gluth. And in a second here, I'm going to tell you a little bit more about him. But before I do that, Meredith, will you please remind the people in the audience what it is we do on the show?
Sure, Moni. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge.
Awesome. And today our guest is Dr. Aaron Gluth. He is a graduate of the University of Virginia Medical School. He did a combined internal medicine psychiatry residency at Emory. He is currently an assistant professor of medicine and behavioral sciences, both an academic hospitalist and a med psych consultant, all at Emory. We are so grateful to have him. And some of his interests include medical care of patients with severe mental illness, diagnostic reasoning, and medical ethics. And he is a dad to a 7-month-old, which we've been told is very cute.
We've been told.
Great. And with that, let's jump straight into it. Aaron, we're going to do some rapid fire questions. Just kind of tell us about a little hobby or interest that you do that's not medicine.
Sure. So I'm a big, unironic fan of Nicolas Cage. Big fan of almost everything that Nicolas Cage does, and also a fan of horror movies, B movies. And if you put Nicolas Cage in a horror B movie, then I will absolutely clear my calendar.
Has he done such film?
Oh, yeah.
Okay.
Yeah, he's done a lot of weird stuff.
Yeah.
Vampire's Kiss.
Okay.
Probably my favorite. It's like an 80s movie about a narcissistic literary agent who becomes convinced he's becoming a vampire.
Okay.
So, really
Did you
stuff.
end up watching the immeasurable weight of astounding talent or whatever it is called?
Yes. The unbearable weight of massive talent. Right?
Yes.
Yeah.
Did you end up watching that? I knew you were on the
Yes.
fence last time we talked about
Loved
this.
it. Thought it was great.
Yeah.
Pablo Pascal is also great. So
Yes. It was kind of like a buddy cop movie there for a little bit.
yeah.
Yeah. Meredith, you have any other questions about Nicolas Cage?
I got none. Oh, I have a lot, but not like that would be a whole separate podcast, I think.
That's the B-side episode.
Okay, so next question. Maybe tell us a little bit about some advice or feedback that you've gotten in your career that you found particularly helpful.
Yeah. So it's not exactly a piece of advice that was given directly to me, but I think more of a lesson learned. When I was a resident, I was obsessed with this idea that I wanted to be able to always know the perfect thing to say to patients during difficult conversations. And I think that this came from watching attendings that I really looked up to, and they always seemed to know what to say. And so I thought that I could teach myself this skill, and I was doing a lot of reading about motivational interviewing and psychodynamics and patient interactions. And I was reading a paper by Carl Menninger, who is one of the great preeminent psychiatrists. And he founded the Menninger Clinic. And he wrote in one of his papers, "When in doubt, be human." And I know that's a really simple thing, but I think in that moment in my career, it was really profound because it gave me permission to not always have to know the perfect thing to say to the patient, and that sometimes the most important thing we can do is just be present as a human being with our patient. So that's advice that I'll still hand down to trainees at times.
I think that's a good one. I agree. I have found myself recently, more times than not, or at least more times now than before, using the line like, I don't really know what to say, instead of trying to find that right thing. And I have actually found it's been better for rapport building, even though it kind of ends up leaving that space of not having somewhere to go from there necessarily. But I think that's a good one. And I don't know that we've had that one on here.
Mm-mm. No, I think that's, really well said, actually. All right. Well, any picks of the week, Meredith? Got any?
Can you go first?
Maybe we'll make Aaron go first. No, I'm just kidding. So I got back from Costa Rica like 4 days before coming to San Diego. So my sleep cycle's like doing real well. But my favorite thing that we did was we did some zip lining by Arenal with a volcano. And I hadn't done it since high school. Zip lining Costa Rica's first time. And I don't know, there's just something like really freeing about just kind of dangling from something and feeling pretty safe, actually, which I was surprised by. And yeah, it's not something you get to do every day. So I really enjoyed it. And I hope I get to do it in some capacity. Because the last time I did it was high school, and it was like the Trust Falls space. Like it was a leadership conference. And so this was much better.
That's a good one. Okay, so for picks of the week, so I think last year we did all Austin themed for SHM. So I guess in that vein, I'll do San Diego themed.
Okay.
Although we haven't done it like during this trip, and probably won't because we'll be attending the conference. I think shout out to the San Diego Zoo, which is a very popular site. I know everyone's like already heard of it. But when I went like previously, it was a blast. They do such a great job at like all of the exhibits, and it does not feel like zoo. You feel like the animals have like a lot more open space and are very well taken care of. And so I previously have really enjoyed my time there and would recommend it to anyone who comes here.
Wonderful. Be a fun one for Max one day. Well, those are some great picks of the week, Meredith. Can you take us to our first case from Cash Talk?
We have Mr. Ronald. He is a 59-year-old man with schizophrenia who presented to the emergency room with erratic behavior, worsening paranoid delusions, and auditory hallucinations. On exam, he is found to have a short-length garden hose wrapped around his waist and partially in his rectum. He says having the hose around his abdomen, quote, lets the spirits out. He has an AKI on his initial workup in the emergency room and is admitted to medicine for further management. So right now we have some basic information about Ronald, but what other additional information on history might be helpful at this point, kind of early in his ED course?
Sure. So I think, starting with the basics is really, really important with this patient population. I think it's really important to establish how and why you've ended up at the hospital. We can take that for granted in patients without severe mental illness because we can just ask them, and usually they'll do a pretty good job of telling us. But in our patient population, it's not uncommon that folks are disorganized or guarded or really, really concrete in their thinking. And so it can be a little bit of a challenge. It's not uncommon that I ask a patient, hey, how'd you end up at the hospital? And they say, well, in an ambulance. And then you say, well, no, what was happening at home that necessitated the ambulance? And they say, well, nothing, I'm doing okay. But then you reach out to family and you find out that they are agitated and wielding a knife and suicidal. And so it's really important to get any collateral information that you can get early and often. And so that's one of the first things we'll typically do, of course, with the patient's permission, is we want to reach out and find loved ones, friends, families, landlords, whoever will talk to you and learn more about what's happening. I think it's really important to establish a psychiatric history. And even just starting out with the question, is there or isn't there a previous psychiatric history, is really, really useful. If you have a 59-year-old gentleman like Mr. Ronald coming in and he has no prior psychiatric history and he's newly psychotic, then he's going to get a lot more workup than a Mr. Ronald who's 59 and has been schizophrenic for 30 years. So knowing what your diagnosis is, knowing how long the patient's had the diagnosis, have they been hospitalized before, Have they had suicide attempts? What medications they're on? What they've been tried on in the past? What medications they're intolerant to? I think all those are really important questions. We often do a really good job of establishing baseline level of function in patients who are neuro patients or geriatric patients. And we need to do that as well for patients with severe mental illness. So trying to figure out when the patient is doing well at home, what do they look like? Do they attend to ADLs? Do they attend to IADLs? Do they hold a job down? Do they have social relationships? And how far off their baseline level of functioning are they? Of course, we always want to assess, are there safety issues? So asking about suicidal ideation, homicidal ideation, self-injurious behavior. Is there violent behavior at home? And if you get a yes to any of those questions, then we need to ask more. So if the patient's suicidal, have you thought about the method that you would use? Do you have access to guns? Have you recently purchased a gun? Have you purchased ammunition? Have you made other preparations? Have you written a suicide note? And then asking on a scale of 1 to 10, how likely is it that you would go through with committing suicide? So it's important to ask all of those questions to get a full picture of what's going on at home. We also need to screen for substance abuse. We want to know if our patient's going to be withdrawing, but also comorbid substance abuse and psychiatric illness. The so-called dual diagnosis is really common and it's really complex to treat. So we have to ask or we won't get that information. So I think that's probably where I would start.
I think that's a good segue maybe into maybe the first question that came to my mind, appropriately or inappropriately, is like, why is all of that information important to get as the hospitalist? Because I think sometimes the expectation may be that, psychiatry will be co-managing this patient with me and they're going to get that information. So can you maybe go into why it's important as a hospitalist to get all of that information?
Yeah, I think that's a fair question. And I would say there are probably a few reasons that we might need to be the folks on the front line getting that type of information. Some of us don't work at a hospital that has access to a consult psychiatry team. And so we may be the ones that are needing to get the psych history because there's really no one else to do it. If we are lucky enough to work at a hospital that has a psych consult team, I think we want to establish that a consult is actually needed. Just because a patient has a history of a psychiatric illness doesn't necessarily mean they need a psych consult. Some patients will have chronic auditory hallucinations or chronic fixed delusions, and no amount of antipsychotic or therapy is going to necessarily make that go away. And if you know that this is the patient's baseline and this is chronically sort of where they live, then maybe you can let your busy consult psychiatrist deal with other things. And then just like any other service line, I think we want to be able to intelligently communicate our need for a consult. Just like if we were calling a cardiology consult, we would want to know a little bit about the cardiac history, the anatomy, have they had a cath, and those types of things. And then the final thing I'll say is, safety and Swiss cheese model. So again, our patients can be somewhat guarded. They might not tell everybody everything, but if we have more concerned folks asking the right questions about medication adherence and substance abuse and suicidal ideation, I think it's more likely that we're able to get the clinical information that's going to allow us to keep our patients safe.
Yeah, as you were saying that, I actually had that thought. Like, if we call a nephrologist and we just call them because the creatinine's 1.6 without recognizing, oh, that's the patient's baseline, they have CKD, like that's poor form. I think we can agree. Mm-hmm. And so that's helpful. I think one of the other baseline things that we maybe is probably, it's always pertinent, but probably definitely more pertinent in patients with psychiatric illness, and you're going to be calling a psychiatric consult. And I think in this case, he uses the phrase, lets the spirits out. So I wonder, is it important to think about, like, is he phrasing that from some cultural background? And then, like, maybe is there a language barrier, like that sort of thing? Can you talk a little bit about that?
Yeah, absolutely. I think that's a really important point. We need to always be mindful of cultural differences. We need to clarify often. And if a patient comes from a cultural background that's different than yours, you should have a very low threshold to just ask the question. And that can be a question posed to the patient themselves. That can be the question posed to the family, or even the medical interpreters. I find are really useful resources. And so, asking questions like, "Hey, in your culture, is it common to have this experience? In your culture, is it common to converse with the deceased?" And if you're getting a lot of nods and you're hearing folks say, "Yeah, actually, that happens a lot in my culture," then perhaps you're not looking at a psychiatric illness per se, but more of a cultural phenomenon. There are also there's a really interesting set of culture-bound syndromes, which are psychiatric conditions, but that present a certain way in a certain culture. So I think getting that data point is really important. And of course, language barriers are hugely important in mental health as well as it is for all of our patients. So we really need to make sure that we are utilizing our medical interpreters whenever we can.
So we've talked a little bit about like getting pretty complete history, not just thinking about like medical things going on, but also getting a better understanding of his baseline psychiatric diagnoses and how that's going to go forward. So now maybe let's move like kind of down our presentation. Clearly, I've been working with med students recently, uh, and think about what about on his exam. And I think for us, I am obviously thinking about physical exam medically, but also like their psychiatric like exam, physical exam.
So the psychiatrist version of a physical exam is called the mental status exam, and it's how the psychiatrist describes the patient's clinical condition as objectively as possible. And so the main components of a mental status exam include the following: appearance. So how's the patient dressed? Do they appear disheveled? Are they wearing more layers than you would expect for the weather outside? Are they dressed in really bright, boisterous colors? Then we move on to behavior. What's the patient doing? Are they pacing around the room? Or are they calm and cooperative? After that, we have speech. Is their speech fluid? Is it hyperverbal? Is it pressured and rapid? On the other end of the spectrum, is their speech somewhat laconic, or do they have sparse, spontaneous speech? And then we have motor. Is the patient psychomotor agitated or psychomotor slowed? Mood and affect comes next. Mood is simply stated just the patient's stated mood. And then affect is more of the appearance of what their mood looks like it would be. So you can comment on whether or not the affect is congruent with the mood. Affect may include bright affect, a happy affect, dysphoric, blunted, flat, and then thought process and thought content. Thought process essentially is the way your thoughts are flowing. So are you linear, logical, and goal-directed, which is what we expect for a normal exam? Or are you circumstantial, meaning that it takes a while to get to the point of your conversation, but you get there eventually? Are you tangential, meaning that you're taking lots of off ramps and getting distracted on different topics? Do you have flight of ideas, which means that you're jumping very rapidly from topic to topic without a whole lot of connection? And on the other end of the spectrum, are you having thought blocking or derailing when it seems like your thoughts stop in their tracks? And then thought content. Typically, we were interested in abnormal thought content. So suicidal ideation, homicidal ideation, delusions, paranoia, anything else that the patient might be abnormally preoccupied with. And then we have perceptions. That's generally speaking going to be hallucinations. So documenting that our patient's having hallucinations, either based on them telling us that or us observing that they're responding to internal stimuli. And then I think the most important part of the mental status exam is the cognitive exam. So cognitive exam is so important for our patients. And ideally, all of our patients should get a mini mental or a MOCA or a SLUMS. But those are all very labor-intensive, time-intensive things to do on every patient every day. So we have to have some basic, quick bedside screening tests. And I really think those tests need to go above and beyond A&O times 3. Alert and oriented times 3 is one of my big clinical pet peeves, especially when people say, oh, my patient's alert and oriented times 3, so they can't be delirious or encephalopathic. Orientation is just one of many cognitive domains. So your patient can absolutely be A&O times 3 and still be delirious. I find it more useful to assess for deficits in attention. So asking questions like, can you spell world backwards, serial sevens? The combination of days of the week backwards and months of the year backwards has pretty good sensitivity for ruling out delirium. And I keep bringing up delirium and encephalopathy, and I use those interchangeably. And I'm sure someone will probably try to fight me for that on social media. But I think it's really important that we screen for delirium. And I think we know as hospitalists and internists that delirium's important. It's super common in the hospital. It's associated with increased mortality. It's associated with poorer outcomes, but it's also really sneaky. So delirium can masquerade as any psychiatric symptom or syndrome. So delirium can look like mania. It can look like psychosis. It can look like anxiety. It can look like depression. So if we don't screen for it, then we're gonna miss those subtle cases. Then I think moving on to the more physical part of the physical exam, I think just basics, a good neurologic exam is important because neurologic conditions are really commonly comorbid with psychiatric conditions. And then there are a few specific physical exam maneuvers that maybe aren't part of our usual acumen as internists, but I think are extra important in this population. So I'm always checking for muscle tone. If the patient has cogwheel rigidity, I might worry that they have Parkinsonism, either due to Parkinson disease or due to their antipsychotics causing a drug-induced Parkinsonism. If they have lead pipe rigidity, I might be more worried about neuroleptic malignant syndrome in the right clinical scenario. If they have paratonia, which is sort of that classic variable rigidity, I may worry more about either a dementia or catatonia. Looking for asterixis, I think, is a really high yield exam maneuver. So remember that asterixis isn't always liver. It can also be due to uremia. It can be due to hypercapnia. Certain medication-induced encephalopathies are more common to have asterixis on exam. Gabapentinoids is a really big one. And then if you have a patient on valproic acid who has asterixis, then I might wonder if they have valproate-induced hyperammonemia, which is probably more common than we recognize. Looking for tremor, which might suggest lithium toxicity or hyperthyroidism or, again, Parkinsonism. Other movements like choreiform movements or myoclonus might make us think the patient needs more of a neurologic workup. And then looking for tardive dyskinesia. And that classically, that's going to be involuntary, non-rhythmic movements in the mouth and face, sometimes in the limbs or the trunk. And if we see that in a patient who's chronically on antipsychotics, that's very likely tardive dyskinesia and may have implications for future treatment. And then being mindful of toxidromes. Our patient population is at really high risk of overdose, both intentional and unintentional. So when we see a patient who has new or undifferentiated confusion, I think remembering toxidromes and that they're useful and not just something we had to memorize for step 2 can be helpful. So if we see a patient who's confused and tachycardic and we slip a gloved hand into their axilla and it's bone dry, then perhaps the patient has an anticholinergic toxidrome and they've taken too much of their diphenhydramine, or worse yet, they have a TCA overdose. So those are other things we can miss if we don't look for them.
It seems like this patient definitely, probably, most likely has some active psych issues, but also seems like there might be some medical stuff. So how do you think through patients that clearly need like multidisciplines taking care of them during their hospitalization? You know, I think as a hospitalist, and like you're on both sides of this, so you know, who should be primary, who should be the consulting service? How do you think through that in a way that puts the patient in position to get the best care possible?
Yeah, I think a lot of it depends on your hospital system. So, for instance, if you're lucky enough to have a med psych unit in your hospital system, that's great. And they can handle most of what we handle on the wards on a hospital medicine service. Most hospital systems are not going to have that. And so I think as a general rule of thumb, if your patient has an acute life, limb, or organ threatening process, then they probably need to start out at least on the medicine service. And of course, we're thinking mostly about patient safety. But the thing that we sometimes will not think about as much is, will this patient in their current condition really benefit from a psych hospitalization? And so I always think about the fact that modern psych units are generally set up as a milieu type unit. And what that means is that the patient doesn't spend a whole lot of time in their room. They ideally should be out in the milieu or in the common area, interacting with other patients, going to group therapy, doing some recreation therapy, doing exercise therapy, eating out in the cafeteria with other patients. And so if the patient has mobility issues, if they're tethered to an IV pole, if they have severe pain, dizziness, or they're septic, they're just really not going to benefit fully from the psych hospitalization. Most psych hospitals do have some medicine consultation available. Even the freestanding psych hospitals, that can be anything from a internist to a hospitalist to a family med doc or an APP. But the rate limiting step that we sometimes forget about is support services. So nursing is a big one. Psych hospitals are staffed with psych nurses. They're generally not med-surg nurses. So they may be really good at de-escalating the patient, but they may be really uncomfortable with things like lines and tubes. Often freestanding psych hospitals don't have PT, OT, speech. We don't always have access to radiology services. Equipment can be a really big deal. Sometimes we don't have Hoyer lifts or tube feeding pumps. And there's very rarely a whole lot of access to subspecialty consult services. If the patient has lines or tubes, that's something that can sometimes be a non-starter, even if your patient has done a really good job of staying calm and protecting their permacath or vascath or whatever line they have. They're going to be on a unit with 5, 6, 7, 8 other potentially agitated and maybe somewhat unpredictable patients. So you never know what another patient might grab and pull out. And then all of a sudden you have a medical urgency on your hands. And then it's also tough if you have any kind of infectious disease that requires isolation. Again, on a milieu unit, it's not really designed to isolate the patients, and it's really hard to meaningfully isolate infections. So that's often another exclusion.
Well, I remember very young in my career, I was at Cashlack Midwest, and I was a medical consultant, and I got a chest x-ray. The patient actually got it. And somehow, I knew nothing about the system, so I think I was just getting off on oh, I'm the new person. I don't know what you can do here. They had a huge pleural effusion, and as someone who had not thought through this before, it's yeah, we could do the thoracentesis on the psych floor.
Bold move.
Yeah, that got shot down pretty quick. The isolation piece does get really challenging because I think that exacerbates their psychiatric illness even worse when they're isolated, which is probably why you guys have the milieu units and stuff.
Absolutely. Yep.
For sure. So, and then the other part I think is, lab draws generally aren't as frequent there. They probably avoid having needles on psychiatric units for pretty obvious reasons. And the patient in question, Mr. Ronald, he's got this AKI, and so it probably seems like the medical floor is the best thing for him. So he's coming to us, we've established, and I feel like, especially the longer I do this, we talk about setting expectations for learners, but I think what's really had gone lost on me for a long time is just how important that is to have that conversation with any consultant, but especially when it's almost a patient that needs two very intensive things, psychiatric care, medical care. And I was kind of wondering, what are the important things you think we should establish between the two services right off the bat?
Yeah, I think that's a really good point. And, I think starting with the basics, clear consult question, and that's etiquette, I think, for any consult service. But also beyond that, it's important to recognize that every consult service is a little different. And in the world of psychiatry, there are actually several different consult models. There's a co-management model that's sometimes on med psych units where, you're essentially medicine and psychiatry are collaborators and they're equal contributors to care. There's a patient-centered consult model, which is exactly what it sounds like. The patient really is the primary concern of the consult team. There's the consult liaison model, which is probably a little bit more common, where the primary team is the main focus of the consult team. So they want to answer the primary team's question, help them out, and be of service to them. So it helps to know what type of model your consult service is. It helps to get to know the consult psychiatrist. But I think beyond that, it's clear communication that we should be having with all of our services. So establishing things like, who's going to put the orders in? Are you guys going to choose the medications, the scheduled psychotropic medications? And probably the answer is yes. What about the PRN medications for agitation? Are you going to help me out with that? What do we do if the first round of PRN meds don't work? Anticipatory guidance as far as things like legal status and ability to leave the hospital AMA, that's really, really important. So, what happens if my patient tries to elope at 4 a.m? Are they on an involuntary hold? Have you guys done that paperwork or do I need to do it? And then I think it's also useful to ask the question, well, what do you need from us? Is there any concern that there might be an organic, medical process that's causing the patient to be decompensated? Do you need a medical workup? How can we be of service? So I think just having really clear communication is a good place to start.
I think the other one that I had come up recently was also because the psychiatric meds tend to need to be titrated and it's not like a everyday type thing is I have found it helpful to say like, okay, we're making this dose adjustment. When would you plan on making any further adjustments and when might I see any changes to that? So kind of has helped create like the timeline for my own expectations. And I think that's also gone the other way as you're trying to figure out going forward too for like dispo planning, where might that person be served given that timeline that I'm dealing with?
Absolutely.
I think it's helpful because also, like you mentioned at the top, like psych services are generally very busy consult services. And so if they're planning on making a med change and they're not expecting to see a change for, 3-4 days and we haven't had that conversation, then we're like, man, why aren't they leaving notes? But if right off the bat, I think it makes it easier.
We'll go back to Mr. Ronald. So psych evaluates him in the emergency room and they give you their initial recommendations for medications. They include some anticipatory guidance for, delirium and agitation, if it's unable to be managed by any conservative therapies. They also recommend that you as the primary team are ordering like workup for reversible causes. And they give you the list of, an HIV, syphilis, vitamin D, B12 folate, and a CT head. So we get this a lot where we are. And I feel like there are two philosophies amongst, I think, our hospitalists. One is just get it because you need it for like psych to make their decisions. I think the other one, though, is like half of those I think have been on like things we do for no reason situations too. And so how do you kind of like think through some of that and what's really important? And
Yeah, I think I would agree with you that most of those tests are going to be pretty low yield most of the time. But that said, I would say I tend to get most of them, not all, but most. And the reason is, I guess there are two separate reasons. Some of these tests are for can't miss diagnoses. And so I think syphilis falls into that category. Some of these tests are just low hanging fruit. B12, I think, is a good example of that. So it's just so easy to treat and it really can have, for some people, an impact on their mental health. So why not check it? I think HIV is hugely important. We should be screening everyone for HIV, but especially this patient population. There's a really well-described bidirectional risk association between HIV and severe mental illness. So we absolutely should be checking. Vitamin D, I think, is a very soft call. Vitamin D is actually pretty strongly associated with major depression, but the jury's out on which is the chicken and which is the egg. And importantly, repleting vitamin D hasn't really been convincingly shown to affect depression outcomes. That said, a lot of our patients will end up on the anti-epileptic type mood stabilizers, and they tend to cause osteopenia, osteoporosis. So maybe we have other reasons to check vitamin D. It's certainly not on my must-have list. Folate is one that I would absolutely put on the chopping block. So it performs poorly is a good reason it's on the list of things we do for no reason. I would actually add a couple of tests. Tend to get a TSH on everybody. Again, low-hanging fruit. I check a lot of B1. We see, I think, more and more non-traditional cases of Wernicke's in non-alcoholic patients. So patients with anorexia, patients with food scarcity, gastric bypass. And so, of course, if you're checking a thiamine, you should probably be empirically repleting thiamine while you're doing that. Urine drug screen is really common. Occasionally we'll get a alcohol screen, but I find that to be usually not very helpful. If the patient's on either valproic acid or lithium or something else that has drug levels that you can check, that's always really helpful. And then finally, I get an A1C and lipids on all of my patients. And the reason for that is this population has a tremendous burden of cardiovascular and metabolic disease. And that's largely due to the medications that we prescribe. So I need to screen for these conditions, and that might affect which medications we're prescribing in the future. So that's my approach to the lab workup. Imaging, I think, could be a talk in itself, but imaging in psychosis is actually pretty well studied. I think there are close to half dozen studies looking at MRI and CT in psychotic patients, and the yield is notoriously low. So the yield of actionable results on neuroimaging in psychotic patients is 0 to 3%. So it's not something I'm going to get on every patient. The scenarios where I might consider neuroimaging are patients that have had head trauma, patients with neurologic complaints, patients with a focal neuro exam, cancer patients, and immunocompromised patients. And then I just have a much lower threshold in geriatric patients. But at first pass, I don't really think that our gentleman really meets any of those criteria. So I'm not sure I would get a head CT on Mr. Ronald.
I think the other indication that I think I read about was also if they're anticoagulated.
Yeah, that one kept popping up.
Yeah.
I think that's reasonable, especially if anticoagulated plus fall, 100%.
And I'm assuming the geriatric thing was high risk of falling, so that's why. Okay, I just wanted to make sure there wasn't some other reason.
Yeah, the occasional patient who we get a surprise, they have normal pressure hydrocephalus or, chronic subdurals. So I think that's pretty rare that we find a surprise, but occasionally.
You were speaking the language of the folate and thiamine. I feel like Meredith has a great soapbox about just starting the thiamine, so she's pretty happy over there.
We give it out like candy at Cashlack Southeast. So.
Yeah.
This is true.
Sometimes I'm like, hook me up.
Yeah. So bringing it back to Mr. Ronald, at the top of the case, we talked about how he's got this hose coming out of his rectum. And as we also talked about, he was like trying to let out some spirits. And this is kind of vague language for anybody, I think, trying to decipher that. And so the team, decides, we don't really know what's going on, and it's roughly in the abdominal region. So let's get a CT abdomen and pelvis. And he's been cooperative to this point, but all bets are off when you take someone to the scanner. Like, things always inevitably, go in a direction you're not expecting. And he becomes increasingly paranoid that someone is in the machine is listening to him, and he declines to have the CT. So he's agitated, and the CT tech sends the patient back to the floor. The nurse calls you and tells you to come, asks you to come and evaluate the patient because she's not able to redirect him. So there's a lot of ways we could go here, but I think to start, just like trying to get care for the patient, which is, I think, everyone's goal in the situation. Let's start just with the agitation and like, what are our options here beyond redirection? Because clearly that has failed.
First of all, I think, props to the CashSelect team for having the wherewithal to order the CT. I think it's important to recognize that sometimes psychotic patients can develop hallucinations or delusions around a medical process or a medical complaint. So I think it's really good that we're paying attention to this. In regards to the agitation, I think it's really important to individualize our regimen for addressing agitation. And for a relatively young, robust, healthy patient, it's fine to start with the stereotypical cocktail. That's kind of classically speaking, that's going to be the haloperidol, lorazepam, and diphenhydramine. That's a pretty good place to start. Again, if you're relatively healthy. For a patient who has an allergy or contraindication to haloperidol, there are other good options. We sometimes use ziprasidone, 10 to 20 milligrams IM. Ziprasidone has more effect on the QT than haloperidol, so we have to be mindful of that. I really like olanzapine for agitation. That can be 5 to 10 milligrams IM or even sublingual. Chlorpromazine is another good option, 25 to 50. So we have more options than haloperidol. I think if your patient is moderately agitated and they're trying to work with you and trying to be cooperative, it's reasonable to offer an oral or sublingual option. And that accomplishes a couple of things. It gives them a little bit of autonomy back, but it's also less likely to cause adverse events and side effects. If we're dealing with a patient who's elderly or demented or delirious or at risk for delirium, then we probably should not be doing the full haloperidol, lorazepam, diphenhydramine cocktail. So in those cases, I think it makes sense to get rid of the anticholinergic. Most of the time, we're probably going to be avoiding the benzodiazepine. And ideally, we're just going to go with an antipsychotic and preferably a lower dose of an antipsychotic. So I'm typically going to be choosing a medication dose that's anywhere from 10 to 25% of what I might prescribe for your younger, more robust patient. So that might look like haloperidol 0.5 milligrams or olanzapine 2.5 milligrams. I think it's really important to be mindful of special scenarios where we don't want to go with an antipsychotic. So situations like catatonia or NMS, neuroleptic malignant syndrome, we want to avoid antipsychotics unless the psychiatry team tells us otherwise. So in that case, benzodiazepines are going to be the treatment of choice. In cases of alcohol or benzodiazepine or barbiturate withdrawal, typically benzodiazepines or in some cases phenobarbital are going to be our treatments of choice. And then for patients acutely intoxicated with a sympathomimetic or PCP or some other dissociative, then we're going to go with benzodiazepines there too.
So here's my age-old question. So Mr. Ronald now has come back. Let's assume we found some sort of regimen that has at least calmed him down. And I think you're always treading this line of, I want to make you feel more comfortable, so a little bit calmer, but I don't want you to be, completely out of it either, so you can still participate in your care as well. But I feel like, especially recently, I think Moni and I have both had individual cases where this has come up where we feel like we're treading this line of how do I provide care to this patient? Because every time I'm trying to, I have this roadblock of maybe the agitation or something else, whatever the situation may be, is kind of preventing that care. And I feel like at times that has resulted in this ethical dilemma because it ends up being, well, maybe I am kind of going to take this path of least resistance now. And do we really need that CT abdomen and pelvis because he's saying it's not that bad or, whatever. And so I guess I'm curious, how do you kind of rationalize through that? Because I definitely run into that and you circle in your head in a way.
Despite the patient having psychosis, you want to respect their autonomy and you want to make sure that you're not forcing them, right? Especially if a patient, we've had this situation, right, where the patient's like actively like begging you not for X, Y, or Z test or X, Y, Z lab draw. And then you're kind of in this position of like, but I really need to know because that whatever the answer to this is might actually be making this other thing worse, and like kind of feed each other. And yeah, ethical dilemma.
Yeah, it's a really, really, I think, common scenario for anybody who's practicing in the hospital. And it's really difficult. And sometimes I think the path of least resistance really is maybe respecting the patient's autonomy, sometimes a little too much, because sometimes that's the easier answer. I think the important thing is that we have a framework to work through so that we think about this relatively uniformly and in an organized fashion for each case. I think it's important, before we get into evaluating for capacity and getting into the ethical legwork, really pragmatic things like, do we have any alternative interventions that we might be able to offer that would be more acceptable for the patient? And that doesn't always make a whole lot of sense from a patient perspective. For instance, Mr. Ronald is convinced that the CT machine is listening to him. We would think that the MRI machine was equally as diabolical. Maybe it's not. Maybe he says, well, I've had an MRI last year and it was fun. So it's worth asking the question, can we get the answer another way? Can we provide the treatment in another way that's more acceptable for the patient? I think we have to ask the question, how urgent is this? Is this something that needs to happen right now? Or can we take some time and get our feet under us and perhaps do this a little bit later on in the admission when the medications have taken effect? Asking the question, what is our big picture goal? Sometimes we lose sight of that. We had a case not too long ago involving a patient with poorly controlled type 2 diabetic. And she was refusing her insulin and fighting the nurse every time the nurse showed up to give insulin. So she was being restrained. And we didn't really take the time to think, well, what's our exit strategy? This patient eventually has to go home. No one's going to be restraining her and forcing insulin on her at home. So I think keeping those types of things in mind are really important. We have to ask the question, if the patient doesn't have capacity, can we do things to help them regain capacity so that they can, they can be more autonomous in their decision making? At some point, it sounds like in a case like that, in a case like this, we're going to have to eventually evaluate the patient for capacity, which I think is anxiety provoking for many of us. Importantly, we can't assume capacity just based on the patient's diagnosis. So we sometimes run into that pitfall where we say, well, they have really decompensated schizophrenia or they're demented. Of course, they don't have capacity. And that, in some cases, it's just not true. You can certainly have capacity for certain medical interventions, even if you have severe neuropsychiatric illness. So we have to do the work to determine whether or not the patient does or doesn't have capacity. It's always an interesting question. Will the intervention that we're suggesting help to restore the patient's capacity? If it does, then that may ethically push you a little bit more in the direction to intervene, even over objection, because you're ethically killing two birds with one stone. You're providing the treatment, but you're also giving the patient autonomy back. So the tough place that we often end up is we do the capacity evaluation. The patient doesn't have capacity. It sounds like just broad strokes, Mr. Ronald here probably doesn't. What do we do next? Can we just move forward and do whatever intervention we want to do? And obviously the answer is no. We have to have a surrogate decision maker. And then we still have a lot of ethical arithmetic to do to try to decide, is the intervention worth it? So what's the likelihood of success of the intervention? What are the burdens to the patient? Is it invasive? Is it painful? How long is the patient going to be burdened? Are we talking about 6 months of chemotherapy? What does the aftercare look like? And what does it look like if the patient refuses or can't get the aftercare? And then the nuts and bolts of what are the dangers or risks of making the patient have this intervention over objection. So that might be things like physical restraints, chemical restraints, or even general anesthesia. So I think that the simple way that I think about this is we have to have a two-tiered risk-benefit discussion, the risk and the benefit of the proposed intervention, but also the risk and the benefit of making the patient have that intervention over objection. So sometimes we go through all of that and we decide the juice isn't worth the squeeze. And we often do that with input from the surrogate decision maker who hopefully knows the patient well. And so there are times where we decide there have to be other ways that we can support and care for the patient, and we don't go through with the intervention. Of course, there are times where, especially if it really does seem to be life-changing, life-altering, life-saving, perhaps we will force the intervention, but it's got to be a risk-benefit discussion.
I think along these lines, and not quite in this patient specifically, but you talk about the urgency piece, and the question that came to mind was, so we have a patient who's maybe come in with suicidal ideation, has this other somatic symptom, not entirely sure what it's about, and their depression might be preventing them from being able to be well nourished. And you have some concern like, is this weight loss? Is this intentional, unintentional? Is this cancer? Is this not cancer? Or possibly malignant or whatever. And so is there ever a time, especially when you're wearing that urgency piece, where it's like, maybe this patient actually needs psychiatric care first, and then we kind of route them back into the medical side? Or I don't know how to navigate that.
Yeah, no, I think it's a good point. And depression's a really good example of that. We see a lot of geriatric depression. Those folks tend to have a failure to thrive picture. So they're losing weight. They've probably gotten some medical workup. It may be a little unclear if this is depression. Is it dementia? Is it a GI issue? And I do think that there are cases where if it looks like the main issue is depression, or even if depression is part of what's impeding more robust medical care, we may need to just be as aggressive as we can to get the depression better. And we have tools in the toolbox that can do that. And so I think that the most common example that I see at Cashlack Southeast is ECT. So ECT works really well. It is gold standard treatment for depression and catatonia, and it works faster than medications. And so you may be able to make a really good argument that, hey, we need to get the depression as good as we can get it, as quick as we can get it, and then see what we have left over from a medical standpoint, if that makes sense. So I think it's a valid discussion to have between medicine and psychiatry.
Okay. So, Mr. Ronald, he gets the CT after a few days, and unfortunately we find that he has a new diagnosis of pancreatic cancer, and he's, cooperating with care right now, and MedOnc's been following, and things are going relatively well. And I think we did a good job of talking about when that's not the case. But I think the other thing that we probably need to talk about is kind of the evidence behind the mortality gap for the patients that do have psychiatric comorbidities.
Yeah, it's I think a hugely important topic. And so when you say mortality gap, you're referring to the fact that patients with severe mental illness will die on average 10 to 25 years earlier than similar patients without severe mental illness. So really, really big gap there. And you might assume that those deaths come from suicide or violent deaths, but the majority of that change in or delta in mortality is actually due to cardiovascular disease, metabolic disease, and to a lesser degree, cancer and infection. So the mortality gap is a major problem, and obviously it's our job to fix it. So these are patients that are sick, and they really need internal medicine as part of their care team.
So going back now to Mr. Ronald, has this new diagnosis and seems to be at least stabilized on his current medication. And we want to keep in mind this is definitely a high risk patient when we're thinking about discharge. So now transitioning him back to the outpatient setting, I want to say probably more things that we should think about in terms of follow-ups, care plans and all of that. So can we just maybe talk about the highlights of what you would like recommend for on discharge, what to make sure that they have in their back pocket when they're leaving the hospital?
Yeah, I think, transitions of care are obviously hugely important. Most of this is just doing the things that we do for all of our patients during transitions of care, but maybe with a little bit more attention to detail, if that makes sense. So I think one place to start is making sure that the psychiatric follow-up is close. Sometimes the psych consult team will help with that. Sometimes the social workers will help. But I find that if the outpatient psychiatrist knows that the patient was recently hospitalized, they're often willing to overbook and do a relatively quick hospital follow-up. Becomes tricky when patients don't yet have established outpatient psychiatric care. The wait can be really, really long. The average wait time right now is 67 days for a new psych appointment. But there are things that we can do to hopefully shore up care a little bit while we're waiting. So one is involving any caseworkers that might be involved. A lot of patients are plugged in with either community service boards or through their primary care clinics. They may have caseworkers that can help with appointments and logistics. Sometimes, depending on the home health agency, if you're sending your patient home with home health, some agencies offer psychiatric nurses, which can be hugely helpful. Many, but not all states have a Department of Behavioral Health and Developmental Disabilities. Sometimes the DBHDD can be really useful in wraparound services or getting patients plugged in. Thinking about things like making sure the patient has their medications. Sometimes that, that handing the paper script and good luck, fill this at your nearest pharmacy, maybe that's not enough. So if your hospital has the option for meds to bed where you can physically hand the patient their prescriptions, that's sometimes a step that can help prevent bounce backs. For patients who are really, really high utilizers and are frequently readmitted, we might consider something called an ACT team. That stands for Assertive Community Treatment. And an ACT team is essentially a mobile psychiatry clinic. And it's typically a prescribing provider, a nurse, social worker, therapist, and they actually go to where the patient is in the community and ensure that they're supported, they're taking their meds, they're getting the therapy that they need. So if your patient falls in that category of frequent readmissions or high utilizers, an ACT team can really be life-saving. So that might be something to ask the psychiatry team about.
So I think we've covered a lot in this episode, and we probably should have summarized before this moment, but since we're now at the end, Aaron, do you have any take-home points for us?
Yeah. So I guess to start, patients with severe mental illness are sick and they're getting sicker. We talked about the mortality gap, and they really need good medical care. They need docs who specialize in the care of complex patients, and that's us. Cognitive screening is really important in the care of these patients. Remember that delirium can look like absolutely anything. We should make sure we scale our interventions for agitation, and we should individualize our medications for agitation depending on what type of patient we're dealing with. And if we're dealing with a patient who is refusing care or not accepting standard of care, then we need to potentially assess capacity. We can't assume capacity based on the diagnosis. We should remember that capacity is intervention specific. And if the patient doesn't have capacity, we still have some ethical legwork to do to determine whether or not we're going to force the patient an intervention over their objection.
Awesome. Anything you would like to plug?
I'm not important enough to have anything personal to plug, but I would plug NAMI, that National Alliance for Mental Illness. They're a great resource for patients with mental illness, family members, and providers too. They have information on grants and provider training and all kinds of good stuff. So, NAMI.
Awesome.
Great. Thanks, Aaron.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Still hungry for more? Join our Patreon and get all episodes ad-free, plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox, including our Curbsiders Digest recapping the latest practice-changing articles, guidelines, and news in internal medicine.
And here at the Curbsiders, we are committed to high-value care, practice-changing knowledge, and to do that, we need your feedback. So please email us at askcurbsiders@gmail.com. It also helps a lot when you subscribe, rate, and review the show on YouTube, Spotify, or Apple Podcasts. A reminder that this and most episodes are available for CME credit for all healthcare professionals through VCU Health at curbsiders.vcuhealth.org. A very special thanks to our writers, us, for the episode, and to our whole Curbsiders team. Our technical production is run by the team at Podpaste. Elizabeth Proto does run our social media. She's been all over it for SHM. Jen Watto runs our Patreon. Chris, the Chu Man Chu, moderates our Discord. Stuart Brigham composed this themes music. And with all that, until next time, I've been Dr. Moni Amin.
And I've been Dr. Meredith Trubit. Thank you and good night.